So today's program, as you can all read, this is a special program that we've been doing for several years now with Dr. Gary Owens, who's our guest today. It's, as it reads, it says the ins and outs of insurance and specialty pharmacy. And you can read what today's program is about. I just want to let everybody know that my name is Stuart Schlossman. You're looking at an MS Views and News program, and we are supported for this program by, like it says, Beatrice, Sanofi, Novartis, and Mallinckrodt, and virtually, I will give them a round of applause. We can't hear you. You can clap all you want, but I can't hear what you're doing. All right, so today, you see what Dr. Owens is going to speak about. He will be speaking for about 45 minutes, and then we'll become Q&A, all right? And Dr. Owens is here. He will take it away with you. Thank you.
Well, great, Stuart. Thanks for that kind invitation, and it's always a pleasure to get to chat with this group. Just looking at the header slide, and I'm looking at November 21st, and I'm just remarking, and I don't know how many of you are, where did 2024 go? And more importantly, where did literally a quarter of the 21st century go? I can remember still fretting about Y2K, and it didn't seem like a quarter century ago. So yeah, we're going to be talking about a number of things today. One of the things I'm going to do, just a little background on Medicare. It may be old news to most of you, but I think it's always good to bring everybody up to date on what some of the changes in Medicare, especially some of the changes, many of them for the good as a result of the IRA. So if we can change the slide, I'll tell you how this talk's going to go about. My background, if you've been on these talks before, you know who I am. I practiced medicine for about 14 years and then worked as a medical director and vice president of medical management at a large Blue Cross plan in the Northeast, and have been working more than a decade now in a market access and health economics consulting role, and have a couple family members with MS, so I have a personal interest in that as well as a professional interest in as much as the MS drug market, which exploded after 1993 when they had the first biologic. One of the beta interferons has been a topic of pharmacy management circles ever since then. So with the next slide, we lay out how we're going to spend our time together. Just an update on what you need to know about Medicare. Explain a little bit about a formulary and why formularies are out there. Talk a bit about prior authorizations, how they work, and what you can do if you disagree with a prior authorization decision. We'll presume you would disagree if that prior authorization decision were negative. Obviously, an approval shouldn't result in a disagreement. And then we'll close with maybe 10 minutes talking a bit about biosimilars. The word there is not terribly earth-shaking in the MS market, and then a bit about the growing use and the advantages and occasional disadvantage of telehealth. So let's talk about what you need to know about Medicare. I think one of the first things, and I read this statistic in a medical journal, that a significant number of Medicare enrollees don't really understand the program that they're enrolled in. Now, I might have a more sophisticated audience here because you have a chronic disease, and if you are a Medicare beneficiary, you probably know very well the program. But the next slide really is going to give you an alphabet lesson, the ABCs of Medicare. Part A is that part that you get automatically when you turn 65 or qualify because of disability or certain chronic illnesses. And Part A covers hospital, skilled nursing facility, home health care, and hospice care. Part B is premium based, and we'll talk a bit more about that. It covers your physician visits, most outpatient services, but not all. It covers essential preventive health care services, including certain immunizations, as well as laboratory monitoring, and there's also some home health care interspersed in Part B. I'm going to jump down actually to Part D because that's the most recent addition to Medicare, and that basically is prescription drug coverage through privatized companies. So Medicare itself, the federal government, decided when they introduced Part D back in the early part of this century that it would be a government-sponsored program, but privately managed, since the privatized program. And so why did I skip Part C? Because Part C is actually Parts A, B, and D rolled together in what's known as Medicare Advantage. So in that case, Medicare pays, again, private industry to manage Medicare benefits, and those benefits include all the benefits you get in Parts A, B, and generally Part D as well. So let's dissect each one of these a bit. But before we do that, I just thought you'd be interested to know that Medicare started in July of 1966. And basically, when it first started, what we could see there was basically it cost the U.S. about $7.5 billion, which was no money to sneeze at. Fast forward to 2023, we're now spending somewhere north of $1 trillion on Medicare benefits. Why is that germane? Because the Medicare Trust Fund definitely is running into financing problems, and we may see further changes in Medicare unless the government does some significant overhaul of Medicare funding. So what is Medicare A? And I do apologize, this is a bit of an eye test, but what I really want to focus on, because you already know you get automatically enrolled in Part A when you reach the age of eligibility. We've already talked about what it covers. We also point out there is no premium for Medicare Part A. And basically, it is not a full insurance coverage because you do have a deductible, which in 2025 is going to increase to $1,684. What is a deductible? It's basically what you pay before Medicare begins to pay. In the first 60 days of hospitalization, unfortunately for most of us, hospitalizations don't run beyond 60 days. Medicare pays for virtually all of those costs after you have met your deductible. But then once you get into extended stay, you have a co-insurance, which means you pay part of the hospital stay, which in days 61 through 90 is $421 a day. 10 days, therefore, is $4,200 plus, and you can multiply that by 6 to see that obligation for 60 days of that kind of care, although it only runs for 30, can get up to $20,000. And then days 91 and beyond, that number doubles to $842 for each lifetime reserve day you use, which you have a 60 lifetime reserve days in a lifetime. So Medicare Part A isn't full coverage, and that'll become important when we talk a little bit later. Medicare Part B, most Medicare beneficiaries have Part B. You're not required to do so. You can opt out of Medicare Part B, but they're generally not great reasons to do that. There is a premium. If you're a Social Security beneficiary, as you know, that premium is deducted before your benefit is paid. The range of Medicare Part B cost, because it is means tested, which means the more money that you have as income, whether that income is earned or from retirement funds, 401ks, and other retirement funds, is part of your income. And that range can be anywhere from $185 all the way up to just south of $630 per month. There is a small deductible in Part B. It's only $257, but, and this is a big but, Medicare Part B is what's called an 80-20 plan, which means of the allowed amount by Medicare, Medicare pays 80% and the beneficiary pays 20%, and there is no cap on that maximum out-of-pocket cost. So if you get $1,000 worth of services, you pay $200. If you get $1 million worth of services, theoretically, you could pay $200,000. Now, the reality is most beneficiaries buy supplemental coverage or take Part C to, in essence, reinsure yourself against the somewhat steep co-insurance in Medicare Part B. There's some things I think it's important to remember Medicare Part B does not cover. The good news is the stuff that most of us use, your annual physicals. In fact, Medicare encourages that we all have a wellness exam annually, a lab test, x-rays, blood work, most but not all medical equipment, orthotics and prosthetics. But then again, there are limits. For instance, if you wear certain orthotics, Medicare requires that the shelf life of that orthotic be something between 1 and 4 or 5 years, depending on the orthotic. If you need one sooner, it's typically on you. Covers mental health services, ambulance services, drugs administered in a physician's office or a hospital outpatient department. They're also Part B drugs. But there's some important things that are not covered. Long-term nursing home care, typically not covered unless you have a skilled need requirement. Acupuncture for neuropathy is not covered. It is covered for low back pain, naturopathy, those kinds of things not covered. Routine foot care, meaning if you're just getting routine podiatric care to deal with the minor maladies of your feet and not having any significant pathology, not covered. Of course, cosmetic surgery, one of the few things Medicare prior authorizes. One that I've never really understood, since hearing impairment is a common problem in people on Medicare, as well as a significant impact both on quality of life as well as mental and physical well-being. Hearing aids are not covered. Generally, dental care is not covered. And with the exception of emergencies, care outside of the United States is not covered. And so those are important things to know about your Medicare Part B coverage. So what is Medicare Part C? Medicare Advantage is the name of it. As we've already pointed out, it is an all-in-one alternative to having Parts A, B, and D. I put one large insurance carrier out there. We'll talk about who a few more of those are, but they're offered by private companies. So basically what Medicare does is pay those private companies a fixed fee for each member that is enrolled in that company, and they in turn are required to provide the same or similar services as Medicare Parts A, B, and D. So that's what's called a bundled arrangement. And as I already pointed out, Medicare pays that fixed monthly payment. It is risk adjusted, so the population that has a higher illness burden gets more money from Medicare than a company that has members with lower illness burdens. And that's calculated based off the claims submitted for those enrollees during the course of the year. And pharmacy benefits are generally integrated into your Medicare Part B plan. So you get your pharmacy integrated in with your medical benefit. And as you can see here, when Medicare Part C got introduced in the early part of the century, only a few people were taking Medicare Advantage plans. Fast forward to 2023, that was the year that 50% of all Medicare beneficiaries are in Medicare Advantage, and actually in 2024, that's estimated to be somewhere between 51 and 52%. So we've seen that shift over about 20 years to more and more people being enrolled in Medicare Advantage. And we'll talk about some of the pros and cons of this plan in just a moment. So here basically are some comparisons. You can sort this out for yourself. Medigap coverage, which is that coverage you buy to reinsure yourself against the co-insurance of Medicare Part B, basically typically has a higher premium than Medicare Advantage because of the way the government funds Medicare Advantage. Those plans can charge low, or in some areas they're even able to charge no premium. You do have the freedom to go anywhere to any doctor or facility that participates in Medicare, and that's the vast majority of doctors in the country. You don't have to get any referrals because it is an open network product. As we pointed out, there's a handful of things, even with Medigap, that aren't covered, such as routine visual exams, hearing aids, that sort of thing. But basically, you have very, very broad coverage throughout the US. What are some of the Medicare Advantage plans? Basically, lower premium, so they become much more affordable if you're on a fixed income. However, you may be restricted to an HMO or a PPO network. You may need referrals to see certain specialists, or in some cases, all specialists, although in a PPO plan, referrals typically aren't needed as long as you stay within the network. It can include some pretty nice extra benefits, vision exams, as well as often eyeglass benefits, hearing aid benefits, fitness benefits, and other benefits. And emergency services are provided outside the service area, but routine care ultimately needs to come back into the service area. So anywhere you go in the country, if you have an emergency, it's covered. That's mandated by federal requirements. But once you are stabilized, you then get returned to your service area for coverage. So you have to weigh the benefits: more out-of-pocket costs for more freedom of choice versus less out-of-pocket costs, perhaps for those expanded benefits, but you have to follow the rules. And it's a very individual decision. And why I say that, because you're now probably being bombarded with ads about its Medicare open enrollment time. And now's the time to make your choices for January 1, 2006, and that open enrollment period runs into early December. Some other things I think you need to know about Medicare Advantage is they do have those supplemental benefits, but the irony of it, about a third of those beneficiaries, based on the most recent data that CMS was able to gather, don't use those benefits. So as part of many of the things that changed in the IRA, Medicare Advantage plans will now be required to send you a personalized mid-year notification of your unused supplemental benefits. So if you haven't used your vision benefit or your glasses benefit or your fitness benefit, or maybe other benefits that they have out there, like hearing aids if you need them, it will really list those benefits that you haven't used and point out what it would cost you out of pocket to use those benefits, as well as giving you some information on how to access those benefits. So I think what Medicare is saying really is, we want to educate you, we want to inform you, and if you really need one of these benefits, why not take advantage of it, no pun intended, with Medicare Advantage. So I think it'll be a nice addition to what Medicare is sending it. It's only going to come out once, it's going to come out mid-year, but that certainly gives you plenty of forewarning and plenty of time to peruse those benefits and see if anything is applicable to you. Next slide. Let's talk a little bit about individual Medicare Part D coverage, because if you don't have a Medicare Advantage plan and you don't have actuarially equivalent plan, maybe from a former employer, Medicare Part D is the type of coverage you want to go to, that you would pair up with your Parts A, B, and possibly supplemental coverage. Remember, supplemental coverage doesn't cover drugs. Again, Medicare Part D is privatized, and these companies offer prescription drug coverage to you as a beneficiary. Prior to 2006, none of us had that advantage, and therefore most retail drug costs were out of pocket. Medicare Part D is not free. You do have a premium to pay to that, so you would be paying your Part B and your Part D premium. And I should say, probably the operative verb, Medicare was complex. It's still a little bit complex, but it's getting less and less complex as we realize that the original design back in 2006 was a bit conservative, because I think in order to get the legislation passed, it needed some conservative aspects to the financing. So let's take a look at the next slide and see who the big players are. As you would expect, there are names here that you know. Some of the biggest payers are United Healthcare, Humana, CVS, which is also Aetna, Elevance, which is Anthem, Kaiser, Centene, and a few others. So if you have a Part D program, you're going to be basically getting your Part D coverage from some of the largest health plans in the country, and basically it will be their pharmacy benefit manager affiliated with that health plan, such as CVS with Aetna and Optum with United, or Humana PBM with Humana as the PBM that's managing your Part D benefit. This is the good news. Over on the left-hand side of this slide is what prior to 2024 Medicare Part D coverage looked at like. It had multiple steps. As I said, it was very complex. Basically, you had to pay a deductible, then you got pretty good coverage until you got up to just north of $4,000. Then you fell into what was called the coverage gap, or affectionately known as the donut hole, and you had to pay a good chunk of money in there until you got the catastrophic coverage. And then above $6,500, you basically still had to pay 5% in catastrophic coverage. And the only relief you could get there would be to apply to private foundations for grants to help you. Fast forward to the Inflation Reduction Act. 2024 was the first phase of that. It basically still left you with a deductible, but it was smaller. Your maximum out-of-pocket costs went down from $6,550 to $3,250, but you still had catastrophic coverage. And hang on, the good news is in 2025, your maximum out-of-pocket cost becomes $2,000, and there is no longer any catastrophic coverage for the enrollee. So you're capped at $2,000. And one more nice aspect to that is for those people who, like MS patients who have high drug costs, and you probably hit your maximum out-of-pocket spending of $2,000 in the first month, you can actually spread your payment out for that $2,000 over the course of the year. You don't have to put it all out all at once. So some really big changes in trying to decrease that complexity of Medicare Part D benefit. So what else did you see because of the Inflation Reduction Act? And again, if you're like me and over 65, I probably created an eye test for myself, but the good news is I know how to put it on the slide. One of the things was capping the cost of insulins, not the biologic, or what might be referred to as the long-acting or ultra-short-acting insulins, but the standard biologic insulins are capped at $35 a month per prescription. Vaccines, many of the newer adult vaccines like shingles vaccine, flu vaccine, are all without cost sharing now. We already talked about the $2,000 out-of-pocket cap in Part D. Also remember, Part B premium started at $185, but if your income falls below a certain threshold, you can get a subsidy for both Part D and Part B cost. Some other good news is Medicare, starting with 2025, has been able to negotiate directly with drug manufacturers to lower the price of some medications, some of which may be germane to MS patients, although I don't believe there's an MS drug specifically on that list. And also another thing, as we know, drug companies do raise prices throughout the course of the year, and if those prices go up faster than inflation, some of that has to be rebated back to Medicare. And basically, Medicare is working to really improve access to biosimilars, although that outlook, as we'll see in a few moments, is still not totally rosy for MS patients. So basically, I've already talked about most of this, but I did want to highlight that option of spreading out your out-of-pocket costs over the year. And if that out-of-pocket cost is a hardship for you in January or the first quarter of the year, that option is available to you. So let's just pop right into the next slide, because I now want to talk a little bit about formularies, because you all know and have all encountered a formulary. And so what is a formulary? We're going to define that in the next slide. And really, it's a list of prescription drugs often by generic name, also mentioning the brand name. You probably see those online when you're looking at your health plan or your PBM's formulary. Formularies are developed by medical practitioners, both pharmacists, physicians, and sometimes other ancillary personnel to look at all the drugs that are available. As you know, diseases like MS, which have more than 20 drugs now, 23 or 24, hypertension, which has dozens and dozens of drugs. Even in the anticoagulant world, there are several of them. And not all drugs are created equal. Some offer better efficacy and more value. And P&T committees are basically out there to try to sort out those drugs that offer the best value at the best price. And as you can see, and as I've already pointed out, you have physicians, you have nurse practitioners. Oftentimes you'll engage public health experts who are experts in population medicine. And of course, we like to also include both hospital and outpatient pharmacists on P&T committee. And really the cornerstones of P&T decisions are basically balancing safety and efficacy with the other drugs in the category. Cost generally only comes into play once the decision has been made that the drug is both safe and efficacious and is at least as valuable or perhaps more valuable than other drugs in the category. So why do you care about a formulary? Because really a formulary ultimately determines what you may have to pay out of pocket. This is kind of just a generic, and I don't mean generic drug, but sort of a general overview of a formulary. Basically, most formularies for Medicare have 5 and some have 6 tiers. The first tier is preferred generics. Those are generic drugs where there are probably many what are called multi-source generics. If you take drugs for your high blood pressure or for other common chronic conditions, high cholesterol, there are a lot of generics out there. In preferred generics, you may be able to get with 0 copay or a $5 or $10 copay. Then there's usually the generic category. These are drugs where the generics may be single source generics, or they're high cost generics like a true generic for an MS drug, or a true generic for a cancer drug, like a drug to treat chronic myelogenous leukemia. Then we have branded drugs, and they're the preferred brands where the typical out-of-pocket cost usually is double or triple what the generic drug costs are. Non-preferred drug costs, there you could start paying a co-insurance or a percentage of the drug cost, and then specialty drugs where you are going to be paying a percentage of the specialty drug cost. And on the next slide, I give you a real-world example. But before I do that, I do want to make sure you know what cost sharing is. Deductible, we've talked about, it's what you pay before the benefit starts. Copayment is a fixed amount, which means if the drug costs $100 or $1,000, either one, if your copayment is $20, that's what you pay. Co-insurance, percentage, so that $100 drug at a 10% co-insurance is $10, $1,000 drug is $100, and a benefit maximum, which as you saw becomes important if there's limits on the benefit. Not a lot of that in Medicare, but in other commercial plans there is. If there is a benefit maximum, then you would pay the rest after that. Next slide. So here's that real world example. This is an example from one of those large Medicare Advantage plans that you saw in the earlier slide. And you can see here, they only have 1 tier of generics, but it's the lowest cost. And you pay $25 out of pocket if you get it by mail order, which is a 3-month supply. Notice you're not paying 3 times $25, so there is an advantage to your out-of-pocket costs for mail ordering drugs that you know you're going to be on for maintenance. Preferred brands, you're paying a higher out-of-pocket cost, $80, starting to get pretty steep. But again, notice if you go to mail order, $200 is not 3 times 80, which would be $240. But that's not a small amount of money. Think about it. If you're on 2 or 3 brand drugs, you're now getting up there in some pretty significant monthly costs. Then you have the non-preferred brands, you're paying $110. Preferred specialty drugs, you're paying $175. Non-preferred specialty drugs is the same. And then they have a formulary excluded class, which means there are drugs that this plan, P&T committee, have decided have therapeutic equivalents on your formulary. And the only way you can get those drugs without paying 100% is through a formulary exception process, which means your provider needs to submit evidence that none of the drugs on the formulary are appropriate for your specific medical need, or that the drugs that are on the formulary are ones that you've tried and failed or have intolerance to. So it really, really creates a high hurdle in that formulary excluded category. So here's your new Part D plan, drug phases. Basically, this is just echoing what I talked about before, because everything caps out at $2,000. So basically, you pay your $590 deductible. You pay up to 25% coinsurance depending on the plan you're in, and you really have to look at the plan you're in, or you could be paying multiple co-payments to get up to that $2,000. And after that, everything is covered. Okay, so now everybody's friend and everybody's word that kind of makes you lose sleep at night, the dreaded prior authorization. And the reality is this is a growing area. Why is that the case? Well, prior authorizations generally are done for a couple of reasons. One is drugs that are high cost and the payers want to ensure that they're being given appropriately. The second one is some drugs that not necessarily are high cost, but may have off-label uses that are questionable, or in some cases not appropriate, or have uses that are not covered, such as lifestyle uses or cosmetic uses. So that's where prior auths come into play. Next slide. So what goes on in MS, and I'm going to be specific to MS here because that's my audience. Basically, most MS drugs, including even ancillary drugs that may help manage some of your symptoms, are very, very likely to get a prior authorization. That means that when your physician prescribes the drug, they're really going to need to submit medical necessity and the criteria for why this drug is appropriate for you, typically on standard forms, which can be done online, more online nowadays than anyway, but also can be submitted by phone. And yes, even in 2024, medical prior authorizations are still done by fax. Part of that's because it's still a more secure way than some online. And basically, sometimes when that information comes in, then the physician maybe has to submit additional information. So if the drug you requested is not on the formulary, one of two things can happen. Your physician can reassess the situation and change you to a formulary drug so you have coverage, or they can justify why a non-formulary drug is needed. Remember my comments about maybe you've tried the one or two formulary drugs that are out there, or you have a sensitivity to those drugs, or the drugs that are on formulary may interact with another medicine you're on, making it inappropriate for you to take it. So let's dig a little deeper in prior authorizations. Basically, there's just a little cartoon of the prior authorization form. Basically, the goal of prior authorization is to make sure that you get the appropriate medicine that's safe and effective. And it really basically means that before your drug is paid for by the plan, that the prescribing physician has verified with the health plan that it is an appropriate drug for your particular condition, and that there are no alternative drugs on the formulary that may be equivalent to or maybe even superior to what you're getting. And actually, there are two kinds of prior authorizations. Pretty much ignore the one at the top of this slide because a soft prior authorization basically is the only thing the physician is asked to do is attest that you have a diagnosis. So if you have MS, it would be attesting that the diagnosis of MS has been confirmed. If you have a rare metabolic disease like Gaucher's disease or Niemann-Pick disease or some of those diseases many of you probably never heard of, once the specialist attests that you have that, the product gets approved. Hard PAs are the norm in MS, and it's really what I've already defined. In addition to confirming the diagnosis has been appropriate, and there's two ways to do that. One is, again, a physician attestation, and the other is not typically in MS, but in some rare genetic diseases, providing a copy of the genetic test that verifies the patient has the disease, and then if the criteria are met, you get your product. But there's still a few more steps to go through as we move through this part of the talk. Let's go to the next slide. Generally, prior auths, if everything is there, Medicare by law requires that complete prior auth, and I do want to underscore, probably should have put it in bold, complete prior auth needs to be turned around in 72 hours. And if it is an urgent request, which means the patient's immediate, and the key word there is immediate health and welfare, not longer term, so that if you don't get your drug, you're very likely to have a deteriorating condition. Think something like a very significant infection, where if we don't start you on an antibiotic, you may wind up being worse, has to be turned around in 24 hours. But the real key word there is complete, because many prior authorization requests that come in are incomplete. Then the health plan needs to go back to the physician to get more information. That, if it's done online, can be very quick. If it's done by phone or fax, it really depends on the health plan and the physician or the physician staff connecting. And again, Medicare regulations give that process up to 30 days to play itself out. Now, when you're waiting for your prescription to be approved, 30 days can seem like a lifetime. Then it's not done yet, because once it's approved, whether it's in that 24-hour or 72-hour window, that prescription typically for MS drugs will go to a specialty pharmacy. Once they verify that everything's in line, that you have insurance coverage, that the prior authorization has been met, that drug usually ships. But if you have a responsibility, you still have to pay your payment before the drug ships, which means that's when the specialty pharmacy asks for some form of payment. It could be a credit card or other form of payment. So there's all of that in there that can sometimes seem like an unending delay in getting your prescription filled. So the last thing I want you to be aware of is when a prior auth is denied, it's not the end of the story. And that's even whether it's a drug or another service. So what do you do if you disagree? Well, first of all, every prior authorization letter that comes out for a Medicare enrollee has two things on it. It has a very short rationale of why you're being denied, and it has more than one way to contact your health plan, including a toll-free number and a website. So the first thing you want to do is make that contact, let them know you're considering an appeal, and you want to get information on why you're being denied. At that point, you talk to your doctor, you gather more evidence, and you basically, the appeals clock starts ticking at the health plan. You then make sure that additional information from both you and your doctor get in, and that appeal is then processed by the health plan. But what I want you to understand there, if you are denied, and I want to modify this a little bit because this was listed for a commercial population, if you're in Medicare, that appeal needs to go to an organization who does appeals for Medicare. It does that for the Medicare administrative contractors and Part C plans, and that's Maximus. And if you wish to appeal to a second level, which I highly recommend, that appeal is external of your health plan. And if you're in commercial insurance, in many states like Pennsylvania, where I work for many years, second level appeals are now handled by the state. So you can really get an external to the health plan review of your denial, and it should be encouraged if you think you have a good case. Now, that does add time, and sometimes time can be of the essence. And I realize many people then often talk to their doctor and say, what are my other alternatives except waiting through this process? Okay, biosimilars. Biosimilars are basically something that's relatively new in the drug world. We all know about generics, and I'm going to spend a little time telling you a little bit about biosimilars and how they differ from generics, but I'm also going to show you a little bit about how they might, down the road in MS, help with the cost of many of your therapies. So let's have the next slide. What is a biosimilar? Well, it's an FDA-approved version of a biopharmaceutical. And what is a biopharmaceutical? It's really a very complex biologic drug, typically made by living organisms and typically made through very complex manufacturing processes. And because of that, the FDA gave exclusive rights to the developer of those biologics to produce it and market it exclusively. These are complex biological products, and they're not like generics, and we'll show you that in the next couple of slides. Next slide. So here's the contrast. Biosimilars, as we've already noted, typically are made from living sources, things like yeast cells, other living mammalian cells, which have been re-engineered to produce a biological product. They often require very exacting things like temperature, acid-base balance, circulation of the medium that these living organisms are living in. But the end product that comes out of that is a product that is very, very similar to original biologics. And your first question, well, why isn't it exact? Because again, these products are made by living organisms under conditions that vary over time. Even the biologic process that's the originator, the biologic that was made 10 years ago is not an exact version of the biologic made today because those processes vary over time. So when you develop a new process, it's essentially equivalent, it varies. Biosimilars do get to develop their process faster, and typically because of that, they're less expensive. Generics typically are made out of chemicals. We all know that chemical reactions, once you know how to do it, you can do the same thing over and over again. So it's an exact copy of a brand name drug. Development of those can be very good. You hire medicinal chemists to produce the drugs or tell you how to produce the drugs, and then you can get them on the market. And once you have 4, 5, or 6 generic manufacturers out there, the price of these drugs plummet often to 5 or 10% of what the brand name drugs was. Next slide. So biosimilars, however, are so identical, and we're learning more and more as these have been in common usage. Some of the common areas they've been in use are in anti-inflammatory medications for things like arthritis and psoriasis, certain ancillary drugs to treat cancer, like drugs that help increase white blood cells when you get cancer chemotherapy, or even now some cancer chemotherapy drugs that are commonly used in breast and colon cancer, and some leukemias are out there. And we're learning more and more from both our data in the US, and biosimilars have actually been used in Europe for a few years longer than us, that these drugs are performing almost identically to the originator compounds. And I think we can expect biosimilars to become more and more mature, I should say, in their ability to demonstrate equivalence to the originator compound. So those worries are going off the table. And I think we can all start to get comfortable that just like we got comfortable over generics not being a cheap copy of brand name drugs because they're chemical equivalents, biosimilars are not a poor photocopy of an originator compound. So in MS, we don't have a lot. There is really only one FDA approved biosimilar. It was approved in August 2023. It is not yet on the market, but we hope to see it soon. That FDA approved is Teruco, which is a biosimilar of natalizumab. I did list rituximab because there are biosimilars of rituximab on the market. Rituximab is mostly used in blood cancers like lymphomas and leukemias. It's also used in inflammatory conditions like rheumatoid arthritis, pemphigus, and a few other things. But there is off-label use, not FDA approved, in MS because it is an anti-CD20 therapy and therefore attacks some of the same pathways that drugs like ocrelizumab and ofatumumab attack. And some of you may even be on rituximab as an anti-CD20 therapy. So that would be one place where a biosimilar, again, off-label, but could be beneficial to an MS patient. So the last little portion of my talk, and I promised Stuart I'd end in about 45 minutes, and I think we'll be within a minute or two of that. I do want to talk a little bit about telehealth because that sometimes can seem a bit bewildering. I know I trained in an era when face-to-face encounter with patients was the only way to manage a patient. And yes, there are many benefits of those face-to-face encounters, but there are also many logistical hurdles, such as if you have a lot of disability, getting to your doctor's office can be a chore. So let's just talk, I only have 2 or 3 slides about telehealth because there's really 2 types of telehealth that we really want to talk about. Telehealth and telemedicine. They're both the delivery of medical services using technology, and that technology doesn't necessarily have to be telephone as we often think of tele, but it can be any kind of electronic communication, including web-based communications and other forms of communications. And the AMA has done some surveys on this, and there are certain medical practitioners that I think just naturally can gravitate to it. Radiologists, my goodness, I can have my radiologist in California read my MRI just as well as my radiologist in Delaware because all the images are virtual and can be sent electronically anywhere around the world. Think about psychiatric encounters. Many of them you don't have to be in front of the therapist to see, and even cardiologists who may be managing medication adjustments on patients who are fragile, like heart failure patients, use a lot of telemedicine. So now I'm going to differentiate telehealth and telemedicine. Next slide. Basically, let's start with telemedicine. It's a little simpler. It's only a part of telehealth. It's really limited to physician or physician assistant to patient encounters. Basically, you have to be a healthcare practitioner. You have to play an active role. It typically involves diagnosis and or management of a patient, and it's really basically delivered by digital services. And there are a couple of things it can do that are really good. It can make your physician available to you when traveling is a hardship. It can make your physician available to you if you have an urgent need, and really there may not be an open appointment, but it also has some of its drawbacks. Is sometimes you really do need to be in the company of a physician to review some things. What is telehealth? It's much broader. It can be a physician-patient contact, but it can also be by other healthcare workers. I mean, think of some of the people that can be licensed clinical social workers, dietitians, even exercise physiologists can help instruct in exercises, pharmacists, nurse educators, all of those can use telehealth, and it really, you can review lab reports over that. You can get education about your disease state. You can ask questions about a symptom, and basically, these telehealth services can be a big adjunct. And even now we're seeing digital telehealth services where you get an app on your phone and you can put questions in there like Teledoc or something like that, and you'll get really a pure digital virtual feedback. So there's a really, really broad range of services that you can interact with. And we're even now seeing prescription digital therapeutics, which is an extension of this. There are a handful of therapeutic modalities where the interaction is between you and an app in a virtual environment that creates a therapeutic outcome, such as treating depression, for instance. And here I've really talked about the different types of telehealth. You have the live, you have the remote patient monitoring, where your blood pressure data is uploaded to a site with somebody with a sleep disorder. Perhaps your sleep patterns are uploaded to a website. You can have heart monitors be uploaded and those sorts of things. So we have lots of things now that can be out there, and many of these can be taken advantage of. There are a few drawbacks. Let's look at the next slide. I think one of the big drawbacks is sometimes not everyone is as computer or smartphone or pad or tablet savvy as others, and some people have trouble navigating these platforms. We still live in a world where not everybody has good access to the internet. Sometimes some of these telehealth services aren't covered by insurance. Sometimes state licensure regulations differ. And sometimes some of these services may not be reimbursable by either Medicare or private insurance. But on the other hand, let's look at some of the benefits. You can expand your reach as a physician. You can, for patients who really just need advice or counsel or have some minor issue that they want to deal with, you can really expand that, even see more patients in the course of a day. And of course, for you as patients, on a cold winter day where it's 10 degrees outside and the wind is blowing, and you really are just needing some routine advice or perhaps some prescription refills and have a couple questions to ask your doctor, you don't necessarily have to go into the office. So again, you have to weigh the benefits and the drawbacks of when and when not to use telehealth services. So with that, I have overstayed my welcome by about 4 or 5 minutes. But Stuart, I'm going to hand the floor back to you.
You definitely did not overstay your welcome, and it was a wealth of knowledge and so much needed at this time of year when so many people are looking into making a change. And I'm sure that people are going to be knocking on my door and saying, when are you going to get this published? My answer is going to be fast, because a lot quicker than some of the others, because it is so greatly needed at this point in time. So thank you very much for presenting tonight. We had quite an audience online. For everybody that's online that has a question for the doctor, don't wait for somebody else to ask it. If you have something to ask, please use the red rectangular to the box at the top with the arrow in it. Click on it, type your questions. Please keep all of your questions to what the doctor just spoke about. He is not a neurologist, so he cannot answer questions that you may have specifically about medications or other things to do with symptoms. He can answer what he just presented. All right? Okay, so let's take it away. The first question we have is, if biosimilars are made with living sources, is that different than from a live vaccine?
Oh, very much different. Basically, a live vaccine, we'll start with that. And basically, a live vaccine is a strain of a virus or another pathogen that has been very carefully designed in a laboratory to no longer be capable of infecting a patient, but it is capable, because of things on the surface of that virus, of telling your T cells that, hey, I'm foreign and you need to come to me and react, so that antibodies will ultimately be formed so that when the real thing comes along, say like a polio virus or an adenovirus that causes the common cold, your immune system goes, hey, I know what that is. I've been educated because I got the live but attenuated vaccine. Since I know what it is, guess what I'm going to do? I'm going to kill it off so you don't get sick. The live biosimilars, these are all confined to a big vat, for want of a better term. You have this big vat that looks like an industrial vat that's filled with the live cells. These cells have been genetically re-engineered to introduce a gene to produce something like a drug or a hormone, and they just live their lives merely producing that drug or hormone that can then be isolated by complex chemical and other processes to isolate that drug or hormone, purify it, remove all the living, everything, including any living byproducts, and what you get is the pure drug. So you want to think about these as 10 gazillion little factories in a vat making the drug that's going to help you get better or save your life.
Right, thank you for that. Going slightly off label, so to speak, a person wants to know where they can purchase or get a biosimilar for for anti-inflammatory or for arthritis.
Okay, if you are on a drug for arthritis, say, like I'll use the brand names here, like an Enbrel or a Skyrizi or one of those drugs, then if there is a biosimilar, there isn't a biosimilar for Skyrizi, there is a biosimilar for Enbrel, there is a biosimilar for Humira. In fact, this year saw the launch of about 6 or 7 biosimilars. If you are on one of those drugs, there is a biosimilar. If you're on something like an NSAID or whatever, then you get a generic of that. So it really depends on what the drug is you're on. And my best answer there, talk to your rheumatologist or dermatologist or whomever is managing and ask, is there a biosimilar of my drug out there? And can it save me money? Because depending on the insurance benefit you have and how the biosimilars are structured in price, it's not 100% guarantee that they will save you money, but there's a good chance they may.
Great, thank you. Next question, why is there so much fluctuation in the price of generic products?
Oh, Lord, I wish I knew. Basically, generic manufacturers come and go. There are shortages to certain generic drugs. Sometimes the base chemicals they have to use, the price of them goes up. We see manufacturing shortages all the time, and it's really just basic economics 101. When the generic supply goes down and the demand remains the same or goes up, the price goes up. So, but in general, most generics are going to cost you less. Now, one of the things that has happened with some generics that's a bit of a bad news is there's some generic lines that are not very profitable, and the generic manufacturers drop out of making them. Suddenly you're left with 1 or 2 manufacturers. And basically, again, economics 101, I have what you want, nobody else does, so you're going to pay more for it.
Right, thank you. Which leads to another thing, another situation where a lot of times people get their generic product and if they look closely at the label, they may see that it's made by a different manufacturer than the last time they got it, or it flips around. Why does that happen, and why aren't the pharmacies, such as a Walgreens or a CVS, just using one specific rather than jumping around from manufacturer to manufacturer?
Well, you think about, what Walgreens does. It fills prescriptions, but to stay in business, they have to remain profitable. And sometimes generic manufacturer A raises their prices and B doesn't. Also, the way they get reimbursed is by I want to see if I can explain this easily, because it's not an easy concept to explain. I had to explain it in front of a jury once, that basically the way pharmacies get reimbursed for generics is on what's known as a weighted average of the cost of the generics across multiple manufacturers. So if there's 10 manufacturers, manufacturer A makes 50% of the drug, and manufacturers B through F make the other 50%, then there's a lot of weight that goes on the price of the manufacturer that makes most of the drug and less that doesn't. And that weighted average turns into something called a maximum allowable charge, which means the payer, the health plan, tells the pharmacies, this is the most we're going to pay for this generic. So if you're buying your generic at a price over that, you're going to lose money. No matter how many of those widgets you sell, you don't make money. So as the MAC fluctuates, the acquisition cost has to be balanced against that maximum allowable. I know that was a very, it took me an hour and a half to explain that to a jury. I just did it in 2 minutes for you guys, but it's basically all about reimbursement and having a margin on the generic drug. And I'm right there with you. I get yellow pills some months and white ones the next.
Okay, thank you for that. Rituximab is a biosimilar, and it's very similar to Ocrevus or Briumvi. Why use the rituximab over Ocrevus or Briumvi?
Well, there's a couple of reasons. One is Rituxan was around and used off-label in a number of medical conditions, including MS, long before we had the anti-CD20 therapy. So if your provider was one of those people who used it off-label and you got a good response and you're doing well on rituximab, why not? The second reason is it does have the same mechanism of action of things like ocrelizumab, ofatumumab, and others. And therefore, again, a provider may choose to use that drug. The third reason is that the price point of rituximab, even in its single source branded form, which was Rituxan, was a much lower price point than most of the MS drugs. And therefore, there might be a financial reason for both you and the health system you're in to use rituximab.
Okay, going to the next. Person writes, I'm not on Medicare yet. Would Ocrevus infusion be covered by Medicare Part B or D?
It would be covered by Part B as in boy, because it is a on-site infusion. But take heart, ocrelizumab has just come out with a subcutaneous version that may be administered by a much shorter time and perhaps even converted to a home administration, in which case then it could become a Part B drug. Right now it's a D. Right now it's a Part B drug.
Thank you for that. Next one writes, does Part D cover specifically specialty drugs like Mavenclad?
Now that's going to depend on your exact carrier and what their formulary looks like. So if Mavenclad is on their formulary, it's covered. If it's not on their formulary, remember that category I showed, the non-covered category, then it would only be covered by exception, and your provider would need to justify why other drugs on the formulary are not appropriate for your care. So the answer is you really, and this is vitally important in open enrollment time, if you're looking to switch plans, you want to make sure you've checked online or had somebody who can help you check online to make sure the drugs that you're taking are covered and on the formulary of your benefit plan. Real cogent time to look at all that stuff before the open enrollment period closes.
Correct, thank you. Next, how open are neurologists to prescribing biosimilars?
Well, that is also an it depends answer. I think there are neurologists who already, I think, would consider it, just like there were gastroenterologists who did it for Humira and others. So that's going to be an individual doctor decision. A lot of it might be based on their confidence in their evaluation of the trial data. But I think now that we've had biosimilars out in some disease states for quite a few years, and the data is now growing that biosimilars are safe and effective and not some imperfect copy. I think as we go forward, we're seeing more rapid uptake of biosimilars by all specialists. It never hurts to talk to your neurologist and see, or your MS specialist to see what they think of biosimilars, and especially if you happen to, well, right now, the only option you have for a biosimilar is rituximab, again, off-label. But going forward, never hurts to have that conversation, especially if you can get the same outcome and not have as much out-of-pocket cost.
Great, thank you. The next one is what if insurance denied your functional electrical stimulator? What other options does a person have?
The first thing I would say is grab that letter where they denied it. Like I said, call the 800 number, tell them you want to exercise your right of appeal and get that appeal going. If they still deny it, tell them you want a second level appeal, because that's typically going to go to Maximus if you're a Medicare beneficiary or an independent review organization commissioned by your state. Point is, don't give up, exercise your appeal rights.
That's correct, thank you. Next, we're running out of questions, okay. Next one is a long question. With original Medicare and Part B, excuse me, deductible, got bad eyes. With I don't recognize this. With original Medicare and Part B deductible has been met when, I guess, there is sometimes a dollar amount that is above what Medicare paid, even though Medicare paid less than the Medicare approved amount. Is there any negotiation regarding the maximum you may be billed? Do providers really expect to be paid the maximum that you were billed?
Well, if you have Medicare Part D, you've met your deductible. Remember, Medicare is still an 80-20 plan after that. So if you look across that, there will be the amount the provider billed. There'd be a Medicare allowable. The Medicare allowable, if the provider is participating with Medicare, which I'll assume that provider is, that's the maximum amount of money. So let me just use an example. Let's say the provider bills $200 for a service and the maximum allowable is $100. Medicare is going to pay 80% of that, of $80. You're going to pay the 20 up to 100, and that other $100 they cannot bill you for because in agreeing to participate in Medicare, you agree, pardon me, to take their fees. So that's where your supplemental coverage comes into play, because typically your supplemental picks up that 20%. And also remember, Part B does not have an out-of-pocket maximum. So you could go on the rest of the year incurring your 20% of those charges, and you're going to continue to have to pay that.
Okay, thank you. Of course, I told everybody we have like 1 or 2 questions remaining, so now we got 4 more. Okay.
No worries.
Okay, it's just my eyes can't read anymore. All right, so we have, I'm trying to make this larger. Just give me a moment, everybody.
Take your time, Stuart.
Much. All right, how do we find out if our medication, like Tysabri, will be given a PA on a different insurance?
That's a harder one to find out. Typically, when you look at formularies for a different insurance, part of the requirement of the formulary is to in some way indicate the drugs that require prior authorization. A lot of times you'll see a little asterisk next to the drug or some other symbol, and you have to look down in the small print that'll say PA required. Others are more upfront. There's a big PA in a circle or something like that right next to it. I'm going to warn you, virtually any branded MS drug is going to require a PA. So it is a very safe assumption you're going to need that prior authorization.
Okay, thank you. Next. Next. Is Tysabri authorized through pharmacy benefit or medical?
It's an infusion, so it's a Part B in Medicare, medical benefit drug, or in commercial insurance, typically a medical benefit drug. Remember, it needs to be given by infusion under the supervision of a provider, and also under the conditions of the REMS program that include, JC virus assessment, those sorts of things. So it's a Part B drug.
Thank you. Next, is there a generic for Ocrevus, and which company is manufacturing the subcutaneous injection?
Okay, first of all, no generic because it's a biologic. So if and when the period of exclusivity for Ocrevus or ocrelizumab runs out, that would be a biosimilar. And of course, the only manufacturer is the originator manufacturer who can make the subcutaneous form. They have the exclusive rights to that because they have exclusive rights to the biologic, which is ocrelizumab or Ocrevus brand name.
Meaning that the subcutaneous Zunovo, I think it's called, is manufactured by
Roche and
Genentech.
Yep.
Exactly. Yep. Okay. Next one. Let's see. Novartis has declined my patient assistance due to change in their patient assistance foundation parameters. What can I do to continue on Kesimpta if I can't afford the Medicare out of pocket in 2025?
Oh boy, that's a tough one. The only thing I can say is that there are a number of patient assistance foundations out there. And just because you may have gotten denied by one patient assistance foundation doesn't mean that others can't help you. Now, the problem with all of the 501c3 patient assistance foundations is they're highly dependent on the grant money and other sources that they raise to give out in the way of copayment assistance. They are also bound, they're means tested too, which means if you have too much income, you can, it's typically $500 or 5 times the federal poverty level. So it's a much higher threshold. But my best advice is try multiple foundations and see, 1, do they have an MS fund? 2, do they still have funds available? And 3, do you qualify under their terms?
Okay, thank you for that. Next, could a new insurance deny you coverage for medication, even if one other you have been on for many years?
Typically not. First of all, they have to give you a grace period for continuation of care. And generally, if that's the case, you get grandfathered in, and it often just doesn't make sense for an insurance company to deny. Technically, they could, but I think practically that doesn't happen that often.
What if they switch from like a Medicare Advantage to a supplement which just doesn't cover that drug?
Well, if you switch from a Medicare Advantage to a supplemental, you have to assume that it's a Part B drug. And basically, Medicare covers all FDA-approved Part D drugs. Your problem might be if you switch from Medicare Advantage to a Part D freestanding plan coupled with your Parts A and B, and you have a Part D drug and it's a non-covered drug, they may give you a short grace period and require you to transition to another drug on the formulary. So that could be the issue there.
So the bottom line is everybody that's looking to make a change like that and they're using a specific difficult to manage medication should really do their homework before they just switch to another company.
And you're reading my mind. Do your homework was going through my head when you said that. It's vitally important.
That's correct. All right. Now, the last question that I have, which is a very important question based on what we were just talking about, is what is the benefit for switching from an Advantage program to a supplement with separate Part D or the other way around?
Well, the benefit, it depends on your needs. If you are financially constrained and can't afford supplemental coverage, Medicare Part B, remember, is an 80-20 plan and you have deductibles in both A and B. So you could suddenly find yourself with massive financial responsibilities if you were in Medicare A and B without a supplemental. On the other hand, if you can afford a supplemental, you're already paying your Medicare Part B premium because that's coming out of your Social Security benefit, and you want a broader choice, then the way to go is the A, B, and D plans with a sup. But really, again, it depends on your individual circumstances. You can't make, and let's say you've got hearing impairments and visual problems and you want to take advantage, hearing aids are god awful expensive. They shouldn't be, but they are. And if you need a $5,000 to $8,000 hearing aid, maybe you want to go with an Advantage plan to get that benefit.
Okay. All right. So what I also want to let everybody know is that if you're looking to make a change to like a supplement or an Advantage plan, and you're speaking with people in another state or another area, do not go by what they're paying.
Nope.
Because it's all based on your area. So you really have to speak, and you have to let people know your zip code and where you're located, even within your state, because there can be a difference between, I'm in Florida, there could be a big difference between Northern Florida and Southern Florida, right? Why is that?
There are multiple regions. Yeah, there are multiple
Why is
regions. Well, because Medicare allows Medicare Part C plans to market in by region, and therefore the benefits don't necessarily have to be consistent by region, and not all plans are in all regions. In fact, there are some areas in the U.S. where there are fewer than 2 Medicare Advantage plans, and then there's a federally subsidized one in those areas.
Okay. All right. Well, we are now out of questions, Doctor, and I do want to graciously thank you for your time, your energy to put in to do these programs. I want to thank everybody that was online tonight. Please know that for the month of November, we have one remaining virtual program. That will be next week. It's our mental wellness chat series. And if you don't know about it and you want to get registered, visit our website, www.msvn.org, and just go to where it says join our events and go on there, check out the website. For those that are not on there, it's a great new website. We started in February, and you really need to check it out. All right, Doctor, I can't wait to have you again on next year. All right, and wow, you'll have a lot to talk about with all the changes in 2025.
Oh boy, will we ever? Yeah.
Yep. All right, great. If anybody that needs to
Thank you,
contact me, there are people writing to me right now to ask me about things for here in South Florida. Just send me an email directly, and I'll answer you because I can't stay online now. All right, Doctor, again, thank you. Good night.
Be well.
You too.